let's just start by defining what syndactyly means.
Yeah. So I think about sort of, as we were going to talk about, sort of generic general syndactyly, which is not a simple thing, but it's really where fingers are still together and there's no skin between them. So they're actually fingers that when children are born, that the skin incorporates two fingers, potentially three, or even all the fingers together. And so what we know is that when babies are developing, what we think is that the fingers just don't fully separate. Is that your understanding? And
Yeah, absolutely. We think that as the limb is forming between 4 and 8 weeks of gestation, so super early, the final step is for the fingers to separate. And if that signal doesn't get to all the spaces, then sometimes the fingers stay connected. Typically with skin, but sometimes with bone.
yeah, so there can be bony tethers at the end, and it's sort of like the final touch-ups just didn't occur. But they can be very functional hands, and we know that syndactyly can be kind of have different levels of involvement. How would you say?
Yeah, so whenever the thumb is involved, it's more significant just because we need an independent thumb for function. Um, and sometimes the syndactyly can be partially up the finger. Sometimes it's the entire finger. Sometimes the nails involved. Sometimes there's bone involved. So there are lots of different variations. But typically at the family's preference, we treat this surgically.
Yeah, absolutely. I don't think therapy per se can, stretch it out or get the skin to creep back. So I would say most of the time we do talk about doing surgery. What age do you like to do surgery? Sort of for the maybe the classic sort of middle digits.
Yeah, so um, the hand doubles in size between birth and 2 years of age, and then it almost doubles again. And so there's lots of different factors in play. We want to be done with this before school age, and usually a fair amount earlier. I like 18 to 24 months for most syndactylies. What do you think about that age range? And then are there any other factors you think about with timing?
Yeah, I think that's a great time frame, sort of that sort of middle fingers. But I think, as you mentioned, so when you have different types of syndactyly, like the border digits, so small finger and ring finger, if those have syndactyly, oftentimes there's a bent position of the ring finger. And then for the thumb, if that's with the index finger, it causes the index finger to be bent down. And I think we both agree we like doing that earlier. So somewhere around 6 months, 9 months of age, just so that it doesn't impair the growth of those other digits. So, in other ways, I think 18 months is a great age to do the others.
Yeah. Sometimes there can even be really subtle syndactyly between the middle and ring finger. And, we hear a lot of discussion about does that impact function? You kind of said appropriately that generally it doesn't. It does impact the wearing of rings and things like that.
True.
And that can be a factor for families.
Yeah, and also football is kind of the other thing. The spread of the hand, it could potentially impact that. So deepening the web spaces is both sort of a functional and an appearance type of
Yeah.
surgery, and I think that's important. I think people shouldn't minimize that.
Yeah. And baseball
Oh,
with
true.
wearing the glove.
Yeah, absolutely.
So, all right. So now we have a child who has syndactyly between the middle and ring fingers. They're 18 months of age and they show up to surgery. Let's pretend for this one is just only the skin.
Mhm.
Can you talk about the principles for how you think about reconstruction?
Yeah, so I will say what we typically like to do is use the skin we have. And one of the most important things as we separate the fingers is that we need to create this web space. So we need to create the web space, the commissure between the two fingers. And we want it to, if you look at your palmar side, you really want to have a nice cascade. So we like to use a flap on the top of the hand to kind of recreate that. And then classically, using the edges of the skin can fold over to cover the sides of the finger. But oftentimes, and we feel strong that you have areas that don't have enough skin for coverage. So they're bare areas that we have to figure out a way to cover. And so there's a lot of options for that. What's your favorite option?
Yeah, so the options include essentially skin graft, and if we use skin graft, we have to take that from somewhere, and we like the elbow. Rarely we take it from the kind of belly or groin, and then there are skin graft
But but
substitutes.
not from parents, right? Some parents want to donate, but
Yep, it
can't
has
do
to be
that.
from the child,
Yeah.
and the incisions heal well. But in the last, I don't know, 8 years, we've been using a
Mhm.
skin graft substitute, which means we don't have to take skin from anywhere else, saving a scar, saving time during surgery, and we've been pretty happy with that.
Yeah, absolutely. I think, and there are people who really advocate for mobilizing more skin off the top of the hand and doing what we say is a graftless technique. So using more skin here and drawing it down. I think there are some good techniques for that. We've done some in the past, and I think our go-to though is to use a graft. Yeah.
Yeah, absolutely.
So
Um, does experience matter with this surgery?
I would say absolutely. I think as I've kind of progressed in my career and we've worked together a lot, trying to see there the more you do, the more you understand sort of the fine points of how to decrease lines of tension, how to really make the reconstruction look good and function well and heal nicely. Do you agree?
I do. I think experience matters in all these surgeries, treating children. But you want to do the best you can do the first time. It doesn't mean every surgery ends up perfectly, but it means we've sort of used the best science together with the best of our experiences, and working together, we, you know, believe we do a pretty good job.
Yeah, absolutely. I think the other thing that's important just to mention also is families always want to know how fast things heal. So, what's sort of your post-operative protocol for this?
Yeah, usually we sort of just wrap everything up for 2, but usually 3 weeks, cover everything up and forget about it, come back about 3 weeks, take the dressings off. Sometimes the skin's healed, sometimes we have to do a little work, and then we work to do some scar massage and sometimes a little dressing or even a little brace to put a little pressure to decrease the chance that things creep out. The skin can creep out over time. That's
Yeah.
something we do our best to avoid.
Absolutely. And so we try to, our goal is always never to do an additional surgery, but I think we always kind of mention that everyone's body's different. So everyone kind of builds different types of scars. So there is always a chance there might be a little touch ups needed in the future, but we try
Yeah.
to minimize that.
That's a good point. And like you're suggesting, there are always slight varieties of the child's presentation, whether or not there's associated conditions, whether the
Mhm.
bone's involved. And again, I think that's where kind of working with you makes it fun. And we've
Yeah.
sort of seen it all, I think.
Yeah, absolutely.